to this breakfast meeting to discuss the launch of our new report today, People Power Lessons from the Healthcare Response to Grenfell. We're delighted you could join us. We've got a fantastic panel and plenty of time for Q&A. So just a word of background before I pass on to panelists. I'm Sarah. I'm the Chief Executive of the King's Fund. And as I say, today we're launching our new report, People Power Lessons from the Healthcare Response to Grenfell. The report was commissioned by Central and North West London NHS Foundation Trust, and our research team worked closely with the Grenfell community and Grenfell Health and Wellbeing Service to produce it. The report includes findings from 30 in-depth interviews with people representing a diverse cross-section of the local community, community organisations and healthcare services, as well as recommendations for the wider healthcare system. So thank you to the panellists who've joined this morning, and I'm going to hand over to them each in turn in a moment. Dan Wellings, who's a senior fellow at the King's Fund, is going to give us an initial overview of the report, key findings and set the scene. Natasha Elcock, chair of Grenfell United, is going to offer a perspective from the Grenfell community and highlight how the community and residents brought their voice to the healthcare response. Professor Kevin Fenton is going to take a slightly broader view and give us his sense of the structural racism and health inequalities that play out in the context of Grenfell, but more broadly as well. And then Rob Webster will give us a sense of his reflections, but also how other parts of the health and care system can learn the lessons, are learning the lessons, and what needs to happen next. We'll make sure we've got plenty of time for discussion and a Q&A. And a couple of housekeeping matters before we get going. So we have our hashtag KF People Power if you'd like to comment on social media. We'd love you to ask questions. So please do put that in a Q&A box. We'll be using the Teams function for Q&A, and we will enable camera and microphones so that you can come on and ask your question. But please do, when submitting a question, let us know where you are from. And then a final reminder, we are recording the session and we'll be sharing it afterwards for anyone who wanted to join but couldn't this morning. So please be aware contributions will be on the record. We think and hope we're joined by members of the media today. So the breakfast is taking place sort of in that way. Finally, then, as I say, delighted to have our panel with us. Kevin has to leave us a little bit early, so we'll make sure we put some questions to Kevin before he departs. So without further ado, Dan, I'm going to hand over to you for an overview of the report.
Thanks very much, Sarah, and good morning, everyone. So my name is Dan Wellings. I'm one of the authors of the report, along with my colleagues, Loreen and Shilpa, who I think also are listening in and may well be able to answer questions later on. So what I'm going to try and do is run through what we found as some of the key themes of the report and why we think they're really relevant for health and care systems beyond Grenfell. These are challenges that we think are being faced across the health and care system. And I think one of the key things is, how do we learn from this? How do we bring some of the lessons from Grenfell, and more particularly the response to that wider health and care system? So I think we heard a great deal last week about the tragedy and the fact that this was a preventable tragedy, that residents had raised concerns about health and care. They were not listened to, and opportunities to prevent the tragedy were missed, leading to the fire that resulted in the deaths of 72 people. What we found is that before the fire, trust had broken down between the community and statutory services. We found evidence of structural racism and discriminatory attitudes towards residents. In that initial aftermath, we also realised how much, and this is, I think, one of the first key lessons, how much the community stepped in. And that's one of those questions, which is actually community and how it produces health, how it is an asset. It stepped in that initial response, which initially was seen as chaotic and fragmented. Over time, when it became clear that that subsequent health and care response was falling short of what was needed, when services started to be put in place, one of the key things that I think that was recognised is that it's too easy for systems to think that they understand what's going to work for people. How do you move away from that one-size-fits-all solutions driven by those that are working in the system towards one that's actually driven by what people need in the community? And we'll hear from Natasha about bringing that voice. And what was absolutely clear is this was a community that was not going to be silenced again, and consistently made the case that the health and care response to the fire should be community-led, driven by what's going to make a difference to people's lives. So one example of that was the Screen and Treat program for PTSD, which was very much a top-down delivered issue. But actually what was flagged by the community was it wasn't working in the way that it ought to. And actually worse than that, was creating more trauma in that community. What we recognized is that when the health and care system is faced with things that aren't working, it can be difficult for the health and care system to acknowledge that. And what it required was a different model of leadership. So a few key individuals started to recognize that actually they needed to work differently and had to advocate for new ways of working, listening to the community and acting on those priorities, working as partners. And I think this is one of the second key themes, which is how do you let go of power? How does a health and care system, which is often driven very much by top-down targets, start to recognize that perhaps the answers to these solutions do not lie within? They lie with working with communities as partners and how much that community themselves brings to this. So 7 years on from the fire, I think we can see that working this way is still very much a work in progress. There's also a risk that this is seen as sort of Grenfell exceptionalism. This is a time-limited way of working and a particular response to the fire, rather than actually understanding that there are many systems across the country now that are starting to think, how do we work differently? How do we take into account the strengths of communities themselves and what they bring to the health and care system, and what they bring more particularly to creating health? Natasha and colleagues, I think, have advocated for a long time, and we'll hear from Natasha in a second, but actually also recognizing that if communities are advocating this, the cost, and recognizing the time and what it means for people to be working this way. So I think we think it's a mistake to see Grenfell and the subsequent health and care response as unique. There are clear lessons for the wider system and for individuals and leaders working within it. If you're going to listen, you have to be prepared to act. Too often I've seen, and I've worked in this area for some time now, is that too often engagement or participation or involvement, it often feels like it can feel quite tokenistic or performative. That actually what communities are telling the system is heard, but actually not translated into action. It can't be a separate activity. Natasha and colleagues wrote a blog for us some time ago now where they called engagement functions within health and care systems a buffer between the system and the community. And I think that's true in many aspects. It has to be core business for all. The other thing that we recognized is that whilst the health and care system and different providers and commissioners and so on within it recognized that they needed to be hearing, you can't do it in silos. People don't live their lives in silos. So if you're going to be engaging, too often it can be that the trust is doing engagement, primary care is trying to do engagement, commissioners are trying to do engagement, the local authority is trying to do engagement. But in health and care systems that really want to shift their model, it's how do you listen together? And that requires not just trust in the community, but it requires trust between those services themselves, something that we found was in short supply at times. And finally, I suppose you have to address the issue of structural racism and the role that this is playing. And I think this has been challenging in the area, but we did see evidence of progress. There was a study that was commissioned to understand why Black men in particular weren't accessing services. And actually, many of the solutions that it came up with, you could see starting to make a difference, starting to play out, but you have to acknowledge that structural racism within the system. So I suppose from a King's Fund perspective, what we're saying is that making partnership working with local communities is a challenge. It's a challenge for systems that often feel they have to know best. But actually, it's also the greatest opportunity. And where you can get it right, it can make a huge difference. I'm going to finish with a quote, which I think is really what we found is at the heart of what we've tried to do. I don't think Grenfell's unique. There is a Grenfell that happens in every deprived neighbourhood across the country, every single day, but we don't look at it that way. The story of Grenfell needs to be told not in the context of there's a fire in a unique situation. The only unique thing about it is the fire. Everything else is not unique. Everything else happens every day in every community. So Sarah, I'll finish there, but I would like to finally just thank, there's lots of people I know who are listening in who we interviewed and took lots of time with us. And I just wanted to offer my thanks at this time for people who participated. And I really hope that we can together listen to what we've learned.
Thank you, Dan. That's really helpful and clear and a good summary. Natasha, please do give your reflections.
Hi, good morning. I just want to start by thanking Dan and the team for taking time to actually take on this project and ensure that the voices of the Grenfell community were heard. In regards to the reflection, as you know, Dan mentioned last week, highlighted that every death that happened at Grenfell was avoidable. But what subsequently happened in the days and weeks after that for our community was we were continued to be ignored and continue to have stuff done at us rather than with us. And it was individuals within the local mental health trust that brokered a relationship to deliver services for this community. And it was really, really important that happened because we were in a position of distrust. And I think that stems back before the fire. If you look at some of the health inequalities that we have in North Kensington, especially, that boils down to the fact that the community weren't trusting of the systems that were in place. And it's also a lot to do with the cultural differences. And with those individuals, and the challenge that we set at the time was very much around delivering a service for the people, but working with the people to decide what those services look like and how they can be improved, and also reach out to those that may be distrusting. I mean, all I can say is, you know, and I'm going to keep it very brief, is, you know, 7 years on, we're still working with those systems, those people, those individuals. It's still very much work in progress. But the biggest challenge for us has been the commissioners, the ICB, those that are in charge of deciding what services are delivered in the community. They have been our biggest challenge. They have been the most hindrance to this process. You know, they think that they have the right to decide how services are delivered to us. And it's quite sad because we, you know, as Grenfell United, it was very much a challenge to CNW at the time. Was, you know, this was an opportunity to do things differently so that communities across the country can have services delivered to them that they are in partnership around shaping. And unfortunately, when you have a system that doesn't like the people that it serves, that will always create a negative hold on how services are delivered. Now, I think the report is exceptionally extensive and it really does speak to what was happening and what is continuing to happen in our community. But unless the system, and I really mean the top level system, takes this report and does something different, this was all a waste of time. And I'm going to end it there.
Thank you. Well, that's in a way the perfect moment to segue to Kevin for your perspective, and you know, you speak as somebody in a national level position. Kevin.
Sarah, thank you, and good morning, everyone. And I'd also like to add my thanks to the King's Fund for the report and all the colleagues who participated in sharing their stories about their experiences, about the impact of what they've been through, and most importantly, the ongoing day-to-day legacies of the tragedy and how it continues to shape or not to shape the work that's being done when it comes to improving health. I had the privilege of reviewing this report, and through the lens of having worked through the COVID-19 pandemic response and other pan-London responses where you can see where the failure to engage communities, the failure to mobilize communities and to co-produce responses with communities ultimately leads to poorer health outcomes. Now, there are a number of reasons why that historic and current practice and reticence of engaging community exists, right? On the one hand, health systems often say, you know, we don't have the capabilities to do this. We don't have the sort of staff and the workforce to do this. We're not trained to do this. On the other hand, it's because we're so busy delivering on our health imperatives, looking at key indicators to improve access to waiting times, emergency department waiting times and access, elective recovery, that the work, the deep work that needs to be done to engage communities, to learn from communities and to mobilize communities and to co-produce with communities often gets left behind. We often hear that doing community-centered work and using community-centered approaches takes time and it's difficult, and the community is so angry with us that every time we go to speak to the community, it isn't productive. And I could go on and on about the excuses on one hand, or the reasons that are often given why systems don't embed community participation and mobilization as a key part of what they do. But let's make no doubt about this. Let's be absolutely clear that if you are interested in improving the quality of the services that you're providing to your community, if you are committed to creating culturally competent and culturally appropriate interventions that can help to improve trust and confidence, improve access and the experience of your communities, if you are truly interested in changing health outcomes and tackling the widening health inequalities, which we have seen, especially in a post-COVID world, then community mobilization and engagement must become part of the toolkit and the must-dos for health and care systems. So in reading this report, there are just a few things that I continue to champion and I continue to reinforce, and I will do so with others as we think about the legacies of Grenfell and what it means for practice in London. Very briefly, number one, that community-centered healthcare must be part of the toolkit for what we implement and what we value as healthcare systems, not only in London, but across the system. And that desire to move services from highly specialized secondary and tertiary services back to the community, back to the public with co-production is key. Second, all systems must commit to tackling structural discrimination, including structural racism, and understanding how power influences not only how they're relating to the communities, but how they're relating to their own staff. One of the challenges we've seen, both in Grenfell as well as in the COVID response, is that in the absence of staff within services that look like and that understand their local communities, that power imbalances will remain, that preconceived ideas remain unchecked, and that the sort of cultural competence that is required of systems fails because there's nobody in those systems at high levels and executives which look like, feel like, or understand the experiences of their communities. Third, we must invest in our tools and strategies to mobilize and engage communities. It isn't cheap, but my goodness, it is an important investment if we want to improve access, tackle trust issues, and to think about better outcomes. And fourth, we need sustainable leadership for change in an environment where turnover of staff, both in local government and the NHS, communities move on. Oftentimes, teams which are established to do the work of deep community engagement don't survive reorganizations and organizational transformations. So we keep reinventing the wheels, learning new lessons, building new partnerships. And what builds trust, which is truth, consistency, and time, often gets left behind because of the churn of our systems and the systems moving forward. And finally, a key legacy of this must be that the issues related to trust and confidence, which, as colleagues have said this morning, cannot be solved overnight, especially when they're pervasive and persistent, must require us to build trust and transparency in our decision making. And that has to be built into what systems do, how systems operate, how systems are held to account in their metrics as a key part of changing this moving forward. So Sarah, I'll pause there. Just a few reflections on this, and maybe taking this from the specific to the general about what not only systems in London, but certainly across the country should be taking away from this as well.
Kevin, thank you. That was fantastic. And again, that segues very nicely to Rob, who isn't in London and will bring us a perspective from different parts of the country and sort of different systems. Rob, over to you.
Thanks, Sarah. Thanks. Hello, everybody. My name's Rob. I'm the Chief Executive of NHS West Yorkshire, and I'm the Lead Chief Executive for the Integrated Care System. I'm going to start by paying tribute to Natasha and to everyone at Grenfell United for the leadership that they've shown over the last 7 years and for the impact and the difference that that's made. I think it's obviously something which everybody who's read the report will take away with them, but everybody who's in health and care should ask themselves, is that happening in my system? Do we rely on people to shake us into action rather than taking action ourselves? So I just wanted to say thank you to Natasha and everybody. I know that it won't have been without cost to them and their families. I think this is a really fantastic report, and it's a gift. It's a gift to everybody working in health and care right now. And as Dan said, everywhere in the country there's a Grenfell, there just isn't a fire. And I think that's one of the most powerful things that comes out of this report. I lead an integrated care system, a system made up of the NHS, local government, the third sector, and our communities. And if you look at the statute and if you look at the intention around integrated care systems, they're to design services to meet the needs of people and improve outcomes. That's what we're supposed to be doing. We're supposed to be working as systems together in service of people. And what this report says to me is that there are some fundamental truths that we have to hold on to. That is the first one. We are here to serve. We're public servants. And if we lose sight of that, then what we start to serve is our organisation or ourselves. Even worse, we let our egos take over. And we're not here to do that. We're here to serve the public, all of the public, all of the time. The second fundamental truth is that people have assets and citizens have assets. Just as we heard in the Grenfell response, the first people on the scene in terms of supporting the communities in the aftermath with the community and the VCSE. That's the same in the pandemic with people who were affected by lockdown or shielding. We knew that it was the VCSE and it was the community who were the first to support them. So people have assets. Diversity is a strength. Diversity is a strength. It's not a problem to overcome. And if we see it as a problem to overcome, what we do is other people, and we end up in a situation where we exacerbate stigma, intolerance, structural racism, and seeing people, I think it reflects in the report, as the deserving and the undeserving poor. And we just can't have that, can we? Diversity is a strength that drives forward power and improvement. And the fourth fundamental thing is that we have to collaborate if we're ever going to be successful. And collaboration is really, really hard. It's really hard. It requires conversations, understanding, work, and communication. And it requires people to be able to disagree and still work together. And these things are rare at the moment. So I think this is a report that speaks to some fundamental truths and uses specific examples to demonstrate that when you get to those truths, things get better. Things get better. So you see people as people, you recognise they'll be angry and frustrated with you. You recognise that you're probably part of the problem and you need to change. And when you do, things get better. So I think that if we look at this report and where we are now in the health and care system, we're all expecting Lord Darcy to tell us in a week or two, what the state of the health and care system is. And by next April, May time, we expect there to be a 10-year plan for the health and care system. I mean, I'd like there to be a 10-year plan for the health and care system which speaks to this report and the things in it about people having assets that we have to collaborate in all we do, that there's strength in diversity. And if we see power, not like money, where if you give money away, you don't have any, but more like love, where if you give power away, you get more back, then I think we've got a real chance to improve things. There's a specific reference in the report to ICSs, which I quite liked. I would, wouldn't I, because I lead one. But it's not special pleading. Now, ICSs and their place-based partnerships provide ready-made structures which community leaders need to be part of, through which local authorities, the NHS, and the wider community, including the VC, FSE, can work on jointly agreed priorities. We've got them already, haven't we? Got them already. So that structural piece is really important. What's more critical is the cultural piece. And throughout this report, I think there are references to culture which see changes to the way that people think about power. I'm often challenged in my system, how can the third sector be an equal partner? I say, well, they're the ones with the access to the communities who don't trust us. They're the ones who sprung up to take action in places where we failed to deliver care that meets people's needs. They're the ones who can help us collectively build a team around people, working alongside and with people, which will make a big difference. So I'm really hopeful that Sarah, Dan and the team can give this gift to people who are going to really pay attention. And what I would say to every person who's in a position like mine is read it and ask yourself, is this me? There's a really nice set of questions in the report, which I would ask all chief executives to read and think, is this me? Thank you.
Thank you, Rob. That's really powerful, and we are indeed really committed to making sure this report is sort of seen far and wide. Please put your questions in the Q&A. We've got plenty of time for discussion and debate, and we'd love to hear from you. I've been told Kevin can stay for the whole session, which is great. I'm going to kick off though with a couple of questions, and I've got loads, but I want to dig into this point a little more about, listening and collaboration sounds easy. To do it well can be hard, and there can be some discomfort in that, and it requires some great leadership, and again being open to feedback that might sometimes be difficult. Dan, can I come to you to dig into this first a little bit more? Through the interviews, through the work on the report, there were some fantastic examples of leadership and commitment to this, but it takes quite a lot. It's easy to say, and it requires investment and time. Can you tell us a bit more about that?
There were a number of occasions, I think, where people working in health and care had to just hear that what they were doing wasn't working. But I think I'd also flag, and I think it was Kevin's point, there were lots of staff that were delivering services who knew it wasn't working. There were lots of people who wanted to deliver care in a very human, relational way, who, because the solutions had been designed in a slightly different way, weren't able to deliver the care that they wanted to. So I suppose I'd add to that, Sarah, that it's so important to hear from communities, but it also speaks to Kevin's point, which is there are lots of people that were working in this area who live and work in that community, and they understood that what they were doing was making a difference. So I think staff engagement is really, really important, and recognizing this. I remember a piece of work we did a number of years ago in Wigan, where they were really trying to work in this very different way. And what they recognized, I remember really vividly, where someone said to us that I'm now doing the job that I wanted to do. That they weren't doing the job that they had sort of been told to do, but they knew it wasn't quite working, and they were having to realize that. So back to your question, Sarah, what it really takes is just some humility at times to think, okay, bits of it are working, but we know other bits aren't. It then requires you not having to go back inside again to say, well, what do we do differently? It requires that collaboration and partnership that Rob was talking about. And sometimes it means that you might not end up delivering those services. So I think that was a really important question in the report, that a lot of engagement that the NHS does is at service specific level. But actually, I think the challenge is that the community have felt at times is that, yeah, we're being engaged on very specific things, but we're not having the opportunity to really shape those services at a much more macro level. So we can talk about co-production or engagement, but someone we interviewed put it as well as I've ever heard this actually. They said we were given a menu of options, but we weren't allowed to decide the menu. And I think that's a really good way of thinking about this, which is, if you want to do this work, you're going to have to recognize that you might not have the answers. You're going to have to recognize that some of the services you provide may not exist in their current form, and that's difficult because that does require differences in funding, differences in where money goes. And what was really clear was how much the voluntary sector in that area is doing. But back to Rob's point about equal partners, that at times it didn't feel like that. And my final point on this, Sarah, is that it's very difficult. There's a national role for this as well, because as Kevin said, if your targets that you're being set nationally are different from what you're being told isn't working locally, there's a real dissonance there. So I think there's a question for national bodies to think through, how do you allow systems to work in this way so they're not caught between, do I look up to people who are going to frankly blame me if I don't meet the targets I've been set, and how do you allow systems to look out to the communities that they serve? And I think that's a really important tension in the work we've done.
Thank you. That's great. Natasha, I wondered if you wanted to come in on this point about the menu and being engaged on perhaps specific bits of a service or services, but how you tried to have that or how you did have that conversation back, which is the starting premise is wrong, or you're not listening to us in a way that we need you to. And then just to give notice, I suppose, Kevin and Rob, to pick up on Dan's point, often there are competing pressures, aren't there? And it's this time and this constant target-driven performance management. Some of this stuff is harder to measure done well, but it's incredibly valuable. So as leaders, and with advice for other leaders, how do you create that space and hold this need to deliver day in, day out with creating something deeper and more meaningful? But first, Natasha.
I think for me, that comment around the menu is very, very true. But because we were fortunate enough to meet an individual within the service who was willing to do something different, that was the stepping stone to how we progressed, especially around the mental health, because that was the initial. Mental health was very much what was required at the time. Physical came much later on. It shouldn't have done, but it did. But yeah, when you meet an individual that says, this is how we've always done it, but I'm willing to listen, that changed how we shaped what was going on. And just thinking about how, what that did, because obviously that word co-production, co-design is very much used, community engagement, all of that stuff, but there was a real actual appetite to listen to what was needed. Yes, it was a unique situation in terms of the fire, but the bottom line of it was, I think what resonated with those individuals within the trust was that they could recognize this was happening in other parts of the trust. This wasn't just happening in North Kent, this was happening in other parts. And I think just the fact that there's that willingness to listen to the people. But the menu was very much, this is what you can have, this is how far it's going to stretch, and we're going to dictate it, and we'll listen to you, but ultimately we're just going to do what we want to. And that wasn't, as I said, this is not, there's 2 degrees of separation, and I'm hoping that comes across in the report, that you had a lot of people that were very willing within the Mental Health Trust, and then you had the ICB. And apologies, Rob, it may feel like I'm ICBing this a lot, but you know, that is the bottom line. The ICB prevented the access, prevented, you know, how we could shape the rest of it, you know, how we could, you know, how could they would listen to us. You know, they did a lot of for me, it was a lot of tick box exercising, where you had one side of the service that was saying, no, we're open to change and listen and legacy. And there's one, to this day, and I'm going to say it clear as day, to this day, there's still one element of the service 7 years on that still refuses to listen to this community. So there is a lot of work to do, and hopefully this report will hopefully open some of those avenues and channels that you know, health professionals will use. But you do need the willingness, you do need the people within the service that understand, want to not necessarily understand the communities, but want to understand the communities, that want to understand the people that they serve, because ultimately we are the service users. You know, I had a conversation with a health professional during COVID. You know, I was very much involved with, you know, the communities. You know, how can we engage with our community, because it was already a community that distrusted, you know, around immunizations and stuff like that. And how do we get people to come and have the vaccine? You know, what does that need to look like? And with others within and again, coming back to the Mental Health Trust, who started to talk about cultural competencies and relating to the people within this community, I think that's what you need. You need people that are willing and want to do things differently. And you know, I am under no illusions that this community wasn't given a large amount of money, that they were given a large amount of money. And I get it, in the NHS, it's a very small amount. We're given a large amount of money for the recovery for a very small community. But when that money is mismanaged, and when that money isn't spent in the way it's meant to be spent, there's a lot of more questions to answer. So we could do all of this talk around co-design and how we shape services, but we've got to look also who the purse holders are, and how they deliver that money, how they spend that money. So yeah, sorry, I'm just kind of flitting between my viewpoints on some of these situations.
No, that's really, it's really helpful. Thank you. And I mean, it does jump out at you from the report that, you know, there was a lot of money set aside, and you know, how well was it spent based on what the community was saying it needed is a question that should be reflected on, and we should try to learn from. Rob, how do leaders make time for this and do it really well? And despite the pressure that might be coming down on top to meet targets, how do we drive this change across systems?
Well, I think the first thing to do is to recognise you won't deliver the targets if you don't do this. It's all part of the same thing. I think the report speaks quite clearly. Dan talks quite clearly, and Natasha spoke very powerfully about, you know, we've got to see the person and everything that's going on in their lives. So just give you a couple of examples. Because we are a system, and the ICB is one partner in the system within the ICS, we've all, I think, over the last 6, 7, 8 years become imbued with this worldview. So hospital staff see people coming in and wonder where they've come from, what's their community like, what's it like back at home, in a way that they didn't before. So we've been looking at things like why have we got so many ambulances coming to hospitals and increasing pressure on the hospital, and who's coming in the ambulance. And that was first posited by Mid Yorkshire Hospital in Wakefield. They were saying, well, who are all these people? Why are they turning up? And we quickly found that 60% of people who turned up were from the bottom 2 deciles of deprivation, and 80% of them didn't need any care. So they'd be seen, everything's fine, just go home again, it's okay. And we thought, okay, that's interesting. And then the ambulance service said, well, more people ring. The conveyance rates are about the same, but actually people in deprived communities ring a lot more. And we said, well, what sort of people are they? And what you find quite quickly is you've got different groups of people from deprived communities than you have in more affluent communities. So much more likely to be single mums with kids in damp houses. So how do you sort out ambulance performance when you think about housing? and transport. How do you do that? Well, you work with your local authorities and your community partners. So these things are all linked. Unless you do this work, unless you start to think about what's the root cause of people coming into the system and what happens to them afterwards, then you're just going to keep going round and round the same hamster wheel. So I think as system leaders, we just need to recognise that this is the job. And ICBs and ICSs, I don't need to perform. I don't need to run the local hospital. There are senior people running the local hospital. There are senior people running the local mental health provider. I'm really interested, do they have the right culture, the culture that Natasha describes, where they want to change the services to meet the needs of the local population and to collaborate with others to look at the wider determinants. So it's fundamentally, it's a way of thinking, I guess, which recognises it's the same world. We're a guest in people's lives, and what goes on elsewhere will impact upon how we see them.
Thank you. I'm going to ask Kevin if you want to come in on this point, and then I can see lots of questions coming in. So we'll go to the broader Q&A after you, Kevin.
Thanks, Sarah. I agree with Natasha and Rob on their points. And one of the things I'm always mindful of is that the NHS was designed to be a universal service. And what it does really well is providing the same activities to everybody, irrespective of their background, color, creed, race, in theory. But actually, the reality on the ground is that we're all not starting at the same place when it comes to accessing or taking up NHS services or experiences of NHS services. And what this story is about is how does an organization as large and as complex and under strain as the NHS pivot, especially in diverse communities of whatever types of diversity, to ensure that we're not only providing those universal services, but those targeted services that meet communities where they're at, and through co-production become more valued, more relevant, more appropriate services for those communities. And there's something there, which is the leadership role for those of us working in the NHS to do that, right? Because you can say, okay, what gets measured gets done. But I've seen across the system where what gets valued by leaders and what becomes a priority for leaders can then get transmitted throughout your organization to change cultures and behaviors, therefore leading to better outcomes. So there's a leadership ask here for me, Sarah, with this, which is how do we ensure that this generation of health and care leaders and the people who follow understand, number one, that structural racism exists within our organizations and continues to drive poor outcomes for not only our staff, but our communities as well. And second, that because structural racism exists and discrimination exists, and we have the tools to deal with it, in addition to doing the metrics for what we need to deliver in terms of quality care, and investment in tackling those structural issues are as important in getting good outcomes as well. And this is critical, that mind shift is critical, because if you think of my role as a public health director for the city, I can look across and see your work to try to encourage, to tackle vaccine hesitancy during the COVID-19 pandemic, to get gay and bisexual communities to take up the Mpox vaccine. At the moment, we're looking at low vaccination and screening rates across the city, where some communities, especially if you're in most deprived communities, have very low uptake rates of childhood vaccines or cancer screening programs. That's not the NHS not doing its work. It's because we're not meeting communities where they're at and working and doing that deep work with communities in order to get to better outcomes. And Sarah, whenever we do that hard work, we see the results. We can show that actually by deeper community engagement, mobilization, tackling trust, we can tackle vaccine hesitancy. We have completely demonstrated that if you are interested in working with childhood vaccination rates, then work with your midwives to work with communities and bring communities in to be part of the solution. So, in summary, this for me is not just a metrics issue and pressures that systems are under, because that's going to be a reality of what we're going to have to do moving forward. It is a leadership and accountability question, and it's about how we use our resources to add to the portfolio of things that we're offering that says community-centered approaches are a must-do in order for us to get better outcomes. And those community-centered approaches start internally with our staff and then radiate outwards to our communities so that we're building on and doing the best and getting the best outcomes. And that, I think, is one of the challenges of this report. And I hope it will be one of the legacies of the Grenfell and, of course, the COVID experience as well. Thanks, Sarah.
Thank you, Kevin. That's really powerful. Now, I'm going to go to the Q&A. Robin Duran asked a question which both you, Kevin, and Rob have been speaking to. But Robin, do you want to, you had a key role in the Grenfell healthcare response. Would you like to come on and reflect on the answers or ask a question? If so,
Yes.
please. Yeah, there you go. Unmute, and you might want to turn on your camera.
Yeah, I think my camera is turned on. I don't know if you can see me. Yeah?
Yes, yes.
Hi, Kevin. Hi, Rob. I was the coup who led the Grenfell response. I'm still the so in terms of continuity. We have I'm not the coup anymore, though. One of the questions for me is around how the system is able to flex in terms of its bureaucracy. We're writing a business case at the moment for the continuation of Grenfell. We're also writing, I'm an ICP director in Brent, Rob, so I do understand ICSs and I work at a system leader level as well. And we've been able to apply the legacy learning from the trust and I think from this work into a system level, actually working together at an integrated level. But one of the biggest challenges we have is when we're trying to write business cases to develop new models and ways of working like this and taking the lesson, the wider system does not acknowledge this. So I'm working with colleagues who in fact are on this call today from the ICS, the ICB, to try and pull together a business case around this, but I've done it around some of our young black men in Brent and how we can have better access to mental health services. But it doesn't recognise this way of working. It doesn't recognise that you need to have relationships and build trust, as was demonstrated in this. This kind of working doesn't fit with a natural KPI model. It doesn't fit with value for money and ticking boxes in terms of a business case. So what can you guys do to help us, both at London level, at system level, to help colleagues in back office functions who are still working with those old systems, who won't, if you like, it's a bit like putting a round peg in a square hole. It does not fit, and it doesn't help us in terms of moving this work forward.
Thank you, Robin. Kevin, do you want to come back on that?
Sure. Robin, thank you. Thank you. And this is exactly what I'm speaking about the disconnect between what we know needs to be done and how do you get complex systems to change their behavior. So Robin, there are three things. And as you know, I work at the regional level, regional to national level. So number one, ensure that there's leadership buy-in to the strategic approach that you want to put in place. One of the pieces of work that came out of the COVID-19 pandemic is a pan-London approach to tackling anti-racism within the health and care system, which clearly articulates for all of our leaders what we're expecting to see differently as a result of this work. And that includes leadership, it includes how you treat your workforce, the culturally competent programs you develop, your work as an anchor institution, and building in the importance of these community-centered approaches. And without that strategic approach, Robin, the work with our ICB chairs and chief execs becomes harder because people always say, we don't know what you mean. We don't have a framework for doing this. What is your ask? So we've made it absolutely clear about what we expect to do. Second, to ensure that those leaders are not just talking about that strategy, but actually developing their own organizational approaches to this and really thinking about where they want to focus their efforts to implement this so they can demonstrate the sort of real change that needs to be done. And we have fantastic examples now across the city where anti-racism approaches are being integrated into health inequalities work, and we're sharing and learning from each other across the city. We still have a way to go, but what we're saying is we're going to try to do this differently. And my final reflection, Robin, in getting this work done is sometimes we think and we believe we know what needs to be done, but we haven't yet done the sort of deeper work in engaging critical partners along the journey with us. And that is why I say part of the journey that we have to be on is to ensure that we say and talk about these issues of racism, power, discrimination, that we be brave in saying, actually, this is how this is operating in our organizations and why we need to do things differently. And I think, Robin, in your role and your experience, you could be a fabulous advocate for not only doing the proposals to do things differently, but engaging different kinds of conversations around your partners to help them to get to the place where they realize that this work needs to be done. So I guess what I'm in summary saying is, to tackle this, because it's a complex issue, you need every layer of the system working and aligned towards this change and recognize what you can do to create different conversations locally to tackle. So good luck and look forward to seeing how you get on with this. Thank you.
Thank you. I can see lots of people wanting to come in. There's a similar question which I might put to Rob. Christina Pagel, I don't know if you want to come in. You've got a question, I suppose, about the urgency of how you actually drive some of this change this year. I don't know if you're still with us. If not, I can read this out. So Christina, I was struck by Natasha saying being served by a system.
Can you?
Oh, hi.
Can you hear? Oh, sorry. No, I was just waiting to get unmuted. So, yeah, I was just saying that, I think people are saying really valuable things, but Natasha really powerfully said it feels like you're being served by a system that doesn't like you, and that has to change, right? And presumably that has been the case with staff changes within the NHS over the last 7 years, and the system has stayed in the sense that they don't like their community and they're not listening. And how do you change that? How do you actually hold the system accountable for that failure and change it this year? And so we're not here in 2 years' time, 3 years' time, saying the same thing with another report showing that nothing has changed. And I think I kind of want to know, what is the concrete action that's going to happen to change that?
Well, it's a great question. I mean, Dan, do you want to, what green shoots came out of the report that speak to, I suppose, hope that genuine change is going to happen, and it'll happen now or soon, or is already happening?
Yeah, I probably can't answer Christina's question in terms of that urgency, but I can certainly try and. I think the frustration for me with this approach is it's seen as other to the central business of health and care systems, and it isn't. So sometimes I know we've been working with Robin and colleagues in Brent, for example, and I would flag an initiative in Sussex around the waiting list. So we can think the waiting list is separate from this work, or you can think that a way of tackling the waiting list is to adopt this approach. So in Sussex, for example, rather than just continuing the way they were, they brought 500 people to a leisure centre to have strength-based approaches to why they want a waiting list. And it's recognising that the solution is going to be slightly different for each person. And so for one person, it may well be that they used to exercise, but the person they exercise with isn't around anymore. And that needs to be delivered slightly differently. And as a result of the work they did in Sussex, they reduced the 50% of people who came to that day came off the waiting list. And I suppose that's what, it's not answering Christina's question because there's a huge urgency here. I suppose what I'd flag from this is that I'm really interested in how people receive this report. Do they receive it in a sort of defensive way, or do they receive it in a way where they say, yeah, you know what, let's reset. How do we start again? It's difficult reading. It's something that perhaps we maybe don't agree with every element of it, but yet what do we do with it? And I think that's a really interesting thing for the NHS, that too often when it receives something which is critical of it, it either dismisses it because of methodologically, or tries to say those things didn't happen and reacts in a defensive way. Whereas a really useful way of listening to it is to say, what can we learn from it? how do we use this report? So we're doing this event today, Sarah, as you know, but we're also going to try and work with the system that Natasha and others live in and say, what do you as partners do with this? And I think that's a really interesting question, which is it reflects back to how Robin and others worked, which is you need to be open to the fact that what you're doing isn't working in the way that you might think it is. So that's the answer to that, Sarah, which is, you know, it may or may not happen, but I really hope it does, because it's about learning and it's about being open and it's about recognizing that maybe some of the things you're trying to do with best intentions aren't working, and you need to be open to that.
Thank you, Dan. Rob, I know you want to come in on this one as well.
Yeah, thank you. So I think Christina's question's a really great one. And thanks, Christina, for all the work that you've been doing over the last few years. It's been really fantastic to see. I've learned a lot from it. In terms of the points that Robin made and Christina, I mean, I think political, managerial and clinical leadership sits at the heart of integrated care partnerships as a statutory body with a statutory duty to create a strategy that's going to meet the needs of local people. And you need that clinical, political and managerial leadership to make change happen with citizens. Those things exist now. There needs to be an honest conversation in a safe space where people like Natasha can say to folk, you don't like your own community. Now, my experience of that with local politicians, councillors, etc., they feel like they do embody the voice of communities. I'm very passionate about that, and others are too. So when faced with this kind of challenge, there's got to be a response, but you've got to find a safe space to have that conversation. And our partnership in West Yorkshire has thrived because we've found safe spaces to have those conversations, which have been a kind of, let's look at our feet for a minute and feel a bit ashamed, but then let's get on and do something about it. And to Christina's point, real change happens in real work. So pick something this year that the Integrated Care Partnership could do on an OD piece that says, let's take this report and let's ask ourselves the questions about, is this us? And if not, how are we building on the strength-based approaches that we've got? Because there are brilliant examples right across the country to make the biggest difference that we can to local people and to set ourselves for a future where we're still recovering from the pandemic.
Thanks, Rob. Natasha, do you want to come in on this point?
I just wanted to just come in on Rob's point about speaking to, or people listening and taking on board, or us continuing to challenge that. We have spoken to absolutely everyone, from the Prime Minister to every Secretary of State that we've had, to previous ICB leader to current ICB leader, around the situation. The problem you've got is when you're 7 years on and that system is still deciding that it's not going to listen, that's the bit that's got to change. That's the bit that today, like, we can talk about everything that comes out of this report, but again, it comes back to the willingness and the want. You know, as I said to you, there isn't a person that we haven't spoken to, and a lot of this is around physical health. You know, there are professionals that think that the Grenfell community, or specifically the survivors, didn't experience anything other than a normal house fire. There are people, when they were challenged around whether the Grenfell community should be monitored, whether that should happen or not. That's what we've been fighting for. That's the system we've been fighting for. Mental health is one thing. The problem you've got is when the system thinks it knows best, and in this situation, or professionals think that it's okay to say, oh, well, they don't need monitoring, it's too late, or what are you monitoring for? There's no data. That's what we've been up against. That's what we're fighting against. So unfortunately, you're in a position where, yeah, okay, speaking to your communities is one thing, but actually acting on it is a whole nother ball game. And you know, as I said to you, I can name individuals that just choose not to listen. They choose not to, or they're being ill-advised by professionals who think they know best. And for me, that's the harsh part. There's not a single person that, as Grenfell United, we have not spoken to about the health provision, and hopefully that comes through in the report. But they're not listening. They really aren't listening. And for me, as I said to you, you know, this whole thing, 72 people losing their lives, has to result in change, systemic change. And that starts with the services that think they're the heroes. And I hate to say that out loud, but when you've got a service that believes that they are the hero and that they wish they don't need to change, that's when we've got a fundamental problem.
Thank you. I mean, it does come across powerfully in the report. And, you know, I think something we've been reflecting on at the King's Fund was to Dan's point about how the report is received. You know, some of this stuff is hard. It doesn't always feel comfortable, but that's where you get the change, a sort of openness to listen and act on it. Now, I'm going to go back to the questions because I'm conscious of the time. And I will bring everyone in if I can do. Chris Ham, your question speaks to listening. Would you like to come on and ask it?
Yeah, well, thanks, Sarah, and thanks for organising this and producing the report, which I haven't yet read, but my appetite has been heightened by the discussion so far. So my question was a simple one, really, which is the health and care providers involved with the response to Grenfell were many and varied. And the impression I got from Dan's opening presentation was one of a uniform response, or a response that was uniformly unreceptive, not listening, and so on. My experience is that there's great diversity among health and care providers because they come from different sectors themselves. So I wonder if Dan could elaborate and say a little bit more. Were some better than others in terms of how they engaged with people, how they listened, how they then acted? Or was your criticism meant to apply to pretty much all of them?
Thanks, Chris. Dan?
Yeah, thanks, Chris. I think what we're saying, Chris, is that it's back to my point that if you listen separately, is absolutely key. So it's back to the point about culture. I think that was absolutely what rung true, is that people started to try and listen in different ways, but because it was diverse and it was across, and often back to that siloed point I was making earlier, Chris, which is different people were listening in different ways and with more or less appetite to take on board what they heard. And that's the key thing that I think is the finding in the report, which is what is your appetite to listen? And it's certainly true that we saw in the mental health offer that there was a recognition that they needed to listen, and listen fast was the other reflection. And I think that's the point, Chris. It's not about being critical of this service or that service. It's about what together can you do to listen and improve in terms of coordination. Because I think the NHS, for people, they assume it works as one until they realise that the wiring is not what you thought it was. And I think that's really difficult for those. It speaks to that point of, if you are trying to work with the NHS, I think people on this call will probably know how difficult the NHS is in terms of its wiring. And that's one of the recognitions, that it's not working as one. And that's something that people have to realise as they go along. And that was a challenge for services themselves, was working together, I think, is the other question which Rob has spoken to in terms of that partnership approach. One thing I would flag, Sarah, just for people to look at in the report, and it speaks, I know we've got Kate Ardern, who used to work in Wigan, is that one of the ways that they try to put something in place, which is you do need to understand the people you are serving, with the key emphasis being on serving. And in Wigan, they used to do work on ethnography, which was really having conversations with people in your local community. In the Grenfell area, there's something called Lucy's Walk. So I'm hoping Lucy's on somewhere. But Lucy is a fantastic person who lives, works, and has a long history of being in that area. And they instigated something called Lucy's Walk, which is about people who are coming to work, visit. We did it ourselves in Grenfell area, to spend time. It's a walk you take around for 2 hours in the local area to understand what it means to live and work in that area, and what are the assets that are in place, the community organisations, the Portobello Trust, all of these organisations that do huge amounts of work. So it's Chris's point, yes, I'm not going to sort of single out it's them did well or them. My key point from this is, how do you listen together, and how do you listen with that view of We know there are gaps in the services we're providing, and how do we have the humility to hear that coming back?
Thank you. And that might be a very good moment to bring in Kate, and who I had spotted. And Kate, you've had your hand up very patiently. Would you like to come in?
Thank you, Sarah. And I'm sorry I couldn't put a question in chat, but I don't have a chat function, unfortunately, at home. For those of you who don't know me, I'm Professor Kate Arden. I'm now an honorary professor of public health at Salford University, but I was formerly the Director of Public Health for Wigan Council, Wigan's Chief Emergency Planning Officer, and during COVID, the advisor to the Mayor of Greater Manchester in terms of health protection and emergency planning. Natasha, can I first pay huge tribute to you and Grenfell United? Some of your colleagues came up to talk to Greater Manchester emergency planning officers well before COVID. And can I say to you that we not only were humbled and I guess in awe of what you've achieved, but in terms of trying to hold the system to account, which is, you know, a fundamental challenge, I think, for any citizen. But we did listen and we did incorporate many of your lessons into our COVID response. So the work we did with 10GM, and which I'm still involved with 10GM in terms of COVID response, was absolutely critical. So thank you, because you really did inform our practice and policy in going into a big crisis like COVID. I think just a couple of reflections, Sarah, if I may, in terms of the lessons from Wigan, and thank you, Dan, for making that connection. I think that there are three things I would say. Firstly, it is about that devolution of power and resource, and that has to be that linked to the sense of place. What we do with professionals is that we inculcate them with a sense of loyalty to their specialty, to their service, and to their organisation. But what we don't do is actually embed them as servants of place. And a huge lesson from the Wigan deal was to actually get beyond not just the professional boundaries and the service boundaries and the organisational boundaries, but for everyone to see themselves as servants of place. And therefore, we are all equal in that. Yes, we have different expertise and different knowledge, but all of that experience and knowledge is what's central to place and the citizens of place. Secondly, you have to invest in citizens, and in other words, give up your power. So you have to share your power and resources and invest in citizens' ideas. And I think, Natasha, the system is set up in a way that doesn't do that. In fact, it completely works against it, unfortunately, and reinforces power and control in professional, managerial, and, you know, also we'll have to say political mindsets. People do not share power willingly, ever. It has to be fought and it has to be given up. Thirdly, I think, Sarah, take just on a practical sense of taking this forward, I think this is a really hugely valuable report. I think it doesn't just have lessons for the health and care system, but I think some conversations, for example, with the metro mayors in terms of health devolution would be incredibly helpful in terms of taking some of that agenda forward. It's very much on the mindset, particularly of the northern metro mayors. So I think it's worth a conversation with Andy Burnham, Steve Rotherham. Obviously, I'm happy to be part of that. But also with the emergency planning route. And one of the things I thought, you know, I've always thought for a very long time, is that NHS emergency planning and response has always been in a splendid silo away from multi-agency planning and response. And also in emergency planning, we've always tended to focus on the acute phase and not on the recovery phase. And recovery takes many, many, many years. You know, 7 years after Grenfell, we're still dealing with issues in Cumbria, you know, 10, 15 years after major floods. It's an ongoing process. So I wonder, Sarah, there's a conversation perhaps with Cabinet Office perhaps with the local resilience fora chairs, for whom this is a really live issue, would also be helpful, so that you bring in that kind of wider health system, both in terms of the sort of health devolution agenda, but also the emergency planning and response agenda, because there are so many parallels with what's coming out of the COVID inquiry. Thank you.
Thanks, Kate. Fantastically put, some great suggestions. Now, I knew this would happen. We're running out of time and there's lots of questions and we're not going to get to them all. Can I go to a final one? And then I'm just going to ask the panel to give a final short word, I think, on your hopes for what next. But could I ask Deirdre Maroney to ask her question? And I think it's to Natasha. I don't know, Deirdre, I can see you. I don't know if we can unmute you so you can ask your question.
Yes, my observation is that the difference in Grenfell was the commitment from Grenfell United, their clarity of what they needed and their, yes, energy in trying to get what they needed. How that advocacy, that clarity in other communities?
Thank you, Natasha. I don't know if you got all of that, but it's the question is about the work that you've done, the commitment, the advocacy, the clarity is what's needed, your voice, and how can we encourage and support other communities to I suppose speak out in a similar way?
I get asked this question a lot. I think what everyone really needs to recognise is none of us asked for this to happen. None of us asked, especially me and others that work with the health professionals on this call, have ever wanted to put ourselves in this position. But once we were in it, I think it was about really, really wanting to do right by the people of our community, by the bereaved and survivors, but most importantly, bring about change. How do other peoples do it? I would say don't take no for an answer. The system will always tell you no. And I think it's important that you keep on pushing, be persistent. As I like to call myself, I'm a bit of a nuisance. And there's a few people on this call that would absolutely say yes to that. But I think it's the only way that you get it done. You know, just coming back to the point around COVID, I was working with the London Resilience team as well around the response to COVID and how community groups can work with that. I think it's important that we empower our communities, that they are given the voice and advocacy to do this. But you do need one or two people within the system that are willing to listen. And those one or two people will hopefully open those doors for you. The biggest challenge is keeping those doors open, because once people have heard what they've heard, they don't like to listen anymore. But it's just a case of don't give up and just keep pushing. We all pay our taxes, we all live in this country, and we all deserve for the system to listen to us. And that's not just the NHS, that's the government system. Just keep going and be persistent. They will try and absolutely break you though. Make no mistake about that.
Thank you, Natasha. Right, we're going to do a very quick final, and I'm going to give you the last word, Natasha. But Dan, sort of what next? What are our hopes for this report? And then I'll come to Kevin, Rob, and Natasha.
I think, firstly, just on Natasha's point, there are voices in all these communities. They're just not being heard. We, off the back of this report and our contacts with others connected, went to see a Somalian community group in Birmingham. They're there. People are trying to advocate. They're not being heard. And the amount of work that they're doing for their own community, which is essentially, is saving money to the system, but they're not being heard. So that's the point I'd make to that one, which is that you've just got to work out where those people are and work with them. They're there everywhere. I think the King's Fund has a job to do in terms of continuing to work on what we can do to make sure this report has impact. I think it's really interesting for the King's Fund to do work of this type, actually. And how we received it internally is in many ways reflected how it can be received externally, and where we've come to as an organisation. So I think We've got more work to do in this area. You put a series of challenges when we sent it to you, Sarah, which is why doesn't this happen more? And I think that's the question that we need to pick up as an organisation and work with others on and keep pushing. So I think the King's Fund will try and do as much as it can to pick up the suggestions today and keep working with Natasha and others.
Thank you. Well, I would strongly echo that. Kevin, very brief final word.
Yeah, Dan, Natasha, thank you for such an important and I hope a pivotal morning that we've had together. 3 things that have struck me today. Number one, the core of this is listening to and valuing community voices and ensuring that our systems are held account to doing that, but our systems have the capacity and the capability to do it as well. And this work is hard. It requires funding, support, and sustainable leadership. So the ingredients for success, for listening to and engaging with and responding to community voices are known. Now is the time for us to take this forward. Second, structural racism operates and exists within our health and care system. And as leaders and as users of the system, we need to be able to confront it, talk about it, and act on it. Because at its core, what it's doing is negatively impacting how communities access and trust our services, the experiences that they have, and the outcomes that they have. So another legacy of this is not just saying we need to listen to communities, but we need to do that deeper work of confronting structural racism and discrimination, which is having an impact on the work that we need to do. And finally, to Natasha's point, that getting the change, difficult as it is, must result in meaningful, culturally competent, sustainable programs that can help to change outcomes over a long period of time. We're tired of seeing the 1-year funding cycles, the initiatives which never go anywhere and are never brought to scale. And those are the exact things that you need to have sustainability at scale to change outcomes. And I'm hoping that this report will help to stimulate that conversation as well. Thanks, Sarah.
Thank you. Thank you. Rob.
Yeah, it's pretty simple. I think the in an era of constrained resources, we shouldn't waste the resources that are right in front of us and hidden in plain sight, and that's the people and the communities that we work with. And if we embrace those communities, their expertise, their capacity, then we've got a chance of being successful, delivering care that meets their needs with them and improves outcomes in an environment where racism exists, Islamophobia exists, and structural racism persists. So we've got a real chance to do something different here. And I think at this moment, with the 10-year plan about to come and hearing the powerful testimony of people like Natasha, we really need to do something different.
Thanks, Rob. Natasha.
Yeah, thank you, everybody. I just want to say that Grenfell happened. It should be the catalyst for change in many, many, many systems, not just the NHS, but other systems. And hopefully that's what it will bring. Because if there is one thing that I know that it has cost, it's cost a lot of time to myself. And I'm going to give him a special mention. He's not here today, but Bilal, who alongside me works with the likes of Robin and Fatima and others within CNWL to bring about the small piece of change we did. My challenge will be that this report doesn't get put on the shelf, because that's very often what happens with some of these things. When people don't like what's in them, they put it on a shelf and hope that it will go away. I've heard you guys talk about 10-year plans and stuff like that. That's way out of my world. But let's hope that this can feature in that 10-year plan. I think communities must be valued. I think the world is waking up to that now. I think COVID definitely helped that, because the community were there for those people. And I think this report will hopefully shape some of those, the way forward for how people listen to. But it's also about tapping into the good people within the system that really want to do better by the people that they serve. But as I said, I'm going to just end on the note of I really want to thank Robin Duran and Fatima El Ghannouni, who were instrumental in the recovery, especially in the mental health, and shaping GHWS. Out of everything that's happened these last 7 years, GHWS and helping to shape that service for the community is probably one of mine and Blau's proudest moments, because we knew we were up against the machine, but the machine let us in for a little bit and will continue to let us in for as long as we can. But what I also want to say is, as much as it's all about listening to the community, when you're in a position like myself and Bilal and others that do this unpaid, you need to take that advice and do something with it, because it's really, really valuable. We do all of this without being paid. This is all voluntary work. And we're going to close this laptop and go on to my day job because my bills have got to be paid. But if you're going to listen to your community, or you're going to get them in rooms and take up their time, at the very least you can do is act upon what they're saying to you. And hopefully, as we move forward, that's what professionals across the service, or system, should I say, will do. Don't take people's time and then do nothing with it, because it is valuable. But thank you guys for everything, and especially thanks to Dan and others for pulling together the report. So thank you very much.
Thank you, Natasha. I can't think of a more powerful way to end. We need to do something with this. We need to learn the lessons. We need to act. Thank you, everyone, for joining. The King's Fund's commitment to share this far and wide continues. Please do the same. And we look forward to continuing the conversation in a whole host of ways. But for now, thank you to the panel. Thank you for joining. Have a good day.